Post-polypectomy colonoscopy surveillance, ESGE Guideline, Update 2020. Introduction. This guideline represents an update of the guideline on post-polypectomy endoscopic surveillance published by the European Society of Gastrointestinal Endoscopy, ESGE, in 2013. Previous recommendations were primarily based on estimates of the risk of metachronous advanced neoplasia, advanced adenoma or colorectal cancer, CRC, according to the endoscopic and histological features at the baseline colonoscopy that represented most of the available evidence. According to the Grading of Recommendations Assessment, Development, and Evaluation (GRADE) methodology adopted for ESGE guidelines, a hierarchy across outcomes must be created, and the main recommendation should be based on the estimates of benefit and risk, burden, of the most clinically relevant outcomes. In this regard, risk of CRC incidence and mortality was ranked as a more relevant outcome than the risk of metachronous advanced neoplasia for estimating the benefit of post-polypectomy surveillance. Of note, this applies both to the stratification of baseline risk at index colonoscopy and to the assessment of the efficacy of endoscopic surveillance. Recently, a series of cohort studies assessed the post-polypectomy risk of CRC incidence and mortality with and without endoscopic surveillance. The overall long-term CRC risk following polypectomy appeared to be similar or slightly higher than for the general population or for patients without adenomas. In detail, a 2% absolute long-term CRC risk for post-polypectomy patients without surveillance has been shown, ranging between 1.1% and 2.9% according to the baseline risk stratification. These estimates were confirmed in a surveillance setting, with a 10-year CRC incidence risk between 0.44% and 1.24%, and mortality risk between 0.03% and 0.25%. In addition, the efficacy of surveillance for patients at high risk of CRC appeared to be less than 1%, while it was ineffective in patients at lower risk. Of note, these estimates are much lower than the 3% long-term CRC risk required in one guideline for recommending CRC screening. Overall, this new evidence supports a very conservative and selective approach to post-polypectomy surveillance. As compared with the 2013 ESGE guideline, the roles of some endoscopic or histological risk factors have been questioned. In particular, the risks of multiplicity or of villus histology regarding CRC in the long term seem to be low or negligible. Hence, the relevance of these factors in stratification of the baseline risk is now questioned. Furthermore, additional evidence based on long-term risk of CRC incidence and mortality has become available with regard to serrated polyps, strengthening the previous recommendations. The efficacy of endoscopic surveillance must be weighed against safety and burden. Diagnostic colonoscopy is considered to entail a very low risk of adverse events, with estimates of 0.05%, 0.25%, and 0.003% for perforation, bleeding, and death, respectively. However, these risks may increase in patients with comorbidities or older age. In addition, unfavorable psychological effects of surveillance have also been shown, at least in patients with high-risk adenomas. Colonoscopy capacity is limited and is mainly expended in population-based organized CRC screening programs as either workup of a positive fecal-based stool test or primary screening intervention. The very high prevalence of adenomas in the era of quality assurance and high-definition colonoscopy, up to over 70% of the screening population, mandates a conservative surveillance policy in order to avoid waste of resources. The primary aim of this ESGE update is to incorporate new evidence into the clinical recommendations to be adopted in routine and specific scenarios. Main recommendations. The following recommendations for post-polypectomy colonoscopic surveillance apply to all patients who had one or more polyps that were completely removed during a high-quality baseline colonoscopy. ESGE recommends that patients with complete removal of 1 to 4 adenomas less than 10 millimeters with low-grade dysplasia, irrespective of villus components, or any serrated polyp less than 10 millimeters without dysplasia, do not require endoscopic surveillance and should be returned to screening. Strong recommendation, moderate quality evidence. If organized screening is not available, repetition of colonoscopy 10 years after an index procedure is recommended. Strong recommendation, moderate quality evidence. ESGE recommends surveillance colonoscopy after 3 years for patients with complete removal of at least one adenoma 10 millimeters or greater, or with high-grade dysplasia, or 5 or more adenomas, or any serrated polyp 10 millimeters or more, or with dysplasia. Strong recommendation, moderate quality evidence. ESGE recommends 3 to 6 month early repeat colonoscopy following piecemeal endoscopic resection of polyps 20 millimeters or greater. Strong recommendation, moderate quality evidence. A first surveillance colonoscopy 12 months after the repeat colonoscopy is recommended to detect late recurrence. Strong recommendation, high quality evidence. If no polyps requiring surveillance are detected at the first surveillance colonoscopy, ESGE suggests to perform a second surveillance colonoscopy after 5 years. Weak recommendation, low quality evidence. After that, if no polyps requiring surveillance are detected, patients can be returned to screening. ESGE suggests that, if polyps requiring surveillance are detected at first or subsequent surveillance examinations, surveillance colonoscopy may be performed at 3 years. Weak recommendation, low quality evidence.